So, good afternoon. Thank you very much, early birds, for coming over for the CDE program. Indeed, we are very happy to notice here that there is a good number of audience. I request fellow presenters to kindly mute because there is some sound coming. Please mute. Yeah, thank you for coming in. And the World Oral Health Day celebrations continue, and we are happy that Indian Dental Association Bengaluru branch is providing a wonderful session here. We can say after the food for the stomach, it is food for the it is food for thought. So here, healthy smiles matter. Well, that is all well known. What I will do is I will give a helicopter view of the pharmaceutical industry so that you understand where actually the pharma industry is going and how it is an interesting contribution here. So the pharma industry, which comprises of some very important companies, just notice Roche, which is having around 50 billion US dollars. In Indian terms, it is 3,67,488 crores sales. That is huge, isn't it? Johnson and Johnson, including its OTC products, has got annual sales of 6,08,850 crores. Now that is humongous. Just remember these figures because you will be surprised to note Indian pharma industry has got only 1,80,000 crores sales. I am not talking about a single company. I am saying the entire pharma industry has got approximately 1,80,000 crores sales in India, whereas one company in West has got 6,08,850 crores. So you can imagine what is the humongous profits and sales these companies are generating, and that is the nature of the pharmaceutical industry. Even a distributor in USA has got 307 billion US dollars sales in 2022. Karnataka state's GDP is 270 billion US dollars. Entire state's GDP is 270 billion US dollars, whereas one distributor is in fact the third largest distributor in USA. He has got 307 billion US dollars sales. So that is the huge difference that you can make out. And that's why India's pharma industry stands tall. We are the third largest in terms of volume, but in terms of value, we are the 14th, which means we make very affordable medications and quality is also assured. The largest number of US FDA approved manufacturing facilities outside of India or outside of USA is in India. So you can imagine what a great contribution Indian pharma industry is making. We make 92% of the anti-HIV medications. India supplies 40% of the generic medicines in USA. India also provides 25% of all the medicines in UK. And in the WHO pre-qualification stage, 90% of the formulations approved are from India for the anti-tubercular, anti-malarial, and antiretroviral category. 50 to 60% of the global demand for vaccines is met by Indian pharma. Every third child in the globe who is vaccinated through WHO vaccination program is with an Indian vaccine. And every fifth tablet which is purchased anywhere in the world is manufactured in India. No wonder Medicine Sans Frontiers, MSF, calls India the pharmacy of the world. The global dental market is also growing rapidly. There is a good growth, and the toothpaste market is the largest when compared to other dosage formulations. A good compounded annual growth rate is seen for oral care formulations. Of the rupees 10,000 crores toothpaste market in India, you have got the sensitivity toothpaste market as well as herbal toothpaste market, which is the fastest growing. So Group Pharma, which is operating in this sphere of pharmaceutical industry, is concerned with providing the best of the healthcare products. That is our purpose. So that is why we have 10 first time in India products, which you are all kindly patronizing as dentists. We have collaborated with several international universities, including Columbia University, Queen Mary University, and we have relationships with several colleges and universities in India to provide partnership. This is the Columbia University with which we are collaborating to produce a botanical oral rinse. We are also collaborating with esteemed institutions including KLE and JSS. So we continuously work for our improvement, and that is why our world-class products are patronized by most of the dentists who have come across this entire range. Chyanam is also recommended after the dental filling. Pediflor is the pediatric favorite. And the recent innovation with patented color changing technology is Densive, which provides clean aseptic dentures within 15 minutes and thereby protecting the denture wearer. The world class manufacturing facilities are located at Tarapur and Malur. So, obviously, these are having all the various certifications such as WHO, GMP, etc., and thereby contributing to a world full of healthy smiles and laughter. Now, this is where I would request the participation of all the people who are here. The Dental Rocketry Fun Quiz. I will ask three questions one by one. You have to please type the answer in the chat box. And my colleague Miss Rupa will be saying who gives the answer first. It is like a fastest finger first. The person who gives the answer first will get a gift hamper from Group Pharma KLE. So name the element. Please see the question. Name the element that becomes volatile and is produced by oral bacteria which is responsible for halitosis. You can please type the answer in the chat box. Fastest finger first will get a gift hamper. I'm looking forward for the answers. Please type. Miss Rupa is also looking at the answer. Dr. Prashant sir can also look. The first person who gives the correct answer will get the gift hamper. Please see in the chat box. Anybody can participate. Dr. Prashant sir also can participate. Anybody can participate. Name the element that becomes volatile produced by oral bacteria which is responsible for halitosis. Rupa, any answers have come?
No, sir.
Yeah, you plus.
One night comes like ammonia.
No, not ammonia. You know that. So you just wait. We see who is giving the right answer. You please check.
Sulfur compound, sir.
Who
Maitri.
gave? Who gave the
Maitri
answer?
Sailesh.
Maitri
Maitri
Sailesh. Okay.
Sailesh.
Maitri has given the right answer first. I record it as Maitri Sailesh. Congratulations. I will later give you the email ID to send your address with PIN code. Now, going to the second question. So, the answer to the first question was sulfur. Thank you very much. And now we go to the second question. Name one acid starting with the letter L, which is responsible for dental caries. So, that is produced by the karyogenic bacteria in the plaque or the biofilms. So, please write down the answer. Name one acid starting with the letter L responsible for dental caries. Rupa, are you looking?
Yes,
Anybody?
sir.
Yeah, yeah.
Lactobacillus, lactic acid.
Okay,
Chandrasekhar
take it
Janakiram.
lactic acid. Lactic acid is the
Chandrasekhar
correct.
Janakiram has given, sir.
Oh, the presenter himself. Okay. Dr. Chandrasekhar, sir, thank you very much for this. Now we'll go to the third question. So, the acid which is responsible for dental caries is lactic acid, as Dr. Chandrasekhar, sir, has given. Now we go to the final and third question. Name the most popular anti-karyogenic carbohydrate which has been incorporated in some of our toothpastes and probably other competitor brands also. Name the most popular anti-karyogenic carbohydrate. So that carbohydrate does not encourage the growth of the Streptococcus mutans and other types of bacteria that cause the dental caries. Please type the answer. What is the name of that carbohydrate? Rupa is keenly watching. Fastest finger first. Maitri, congratulations.
Sonal made, sir. Sonal.
Huh?
Xylitol.
Yeah, okay. Xylitol is correct,
Sonal.
Dr.
Dr.
Sonal.
Sonal.
Okay, thank you, Dr. Sonal. You have got the prize. So, name the most popular anti-karyogenic carbohydrate in toothpaste. The answer is xylitol. So, thank you very much for participating in this quiz. This was a very short interaction that we wanted to have. And now I request Dr. Prashant sir to take over. Thank you very much for your keen cooperation. Dr. Prashant sir, you can kindly unmute. The floor is yours. I think Dr. Prashant sir is having his video seems frozen. So it appears that Dr. Prashant sir is having some issue. We'll just wait for Dr. Prashant sir to come and give the onboarding. Dr. Prashant sir, you can please speak. Dr. Prashant sir. Dr. Prashant sir, you can kindly speak. Please take over.
Hello.
Hello sir, you can please take over.
Hello.
New matadi sir. Dr. Prashant sir. Dr. Prashant sir, please talk. I think Dr. Prashant sir is having some issues. I'm waiting for Dr. Prashant sir, then we can move over to the main. Dr. Chandrasekhar sir is ready. I'm waiting for Dr. Prashant sir so that he will officially give you a warm welcome. Dr. Chandrasekhar sir is perfect in his.
Hello.
Hello sir. You please speak, sir. Dr. Prashant sir. Hello. Dr. Prashant sir, you please speak. Matade, doctor. Dr. Prashant sir, you please speak. Dr. Chandrasekhar sir is ready. I think I'll give him a call to gain the instructions on what to do next.
Hello. 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 Sir, I'm not able to hear.
Sir, we can hear you. You please speak.
Sir, please continue.
No, I am through Dr. Prashant sir. You please welcome Dr. Chandrasekhar sir. He is also ready.
Once I'll disconnect Bluetooth. Bluetooth disconnect ಮಾಡಿ.
ಬೇರೆ ಇಲ್ಲಲ್ಲ ಈಗ ಡಿವೈಸ್.
Dr. Prashant sir, ಮಾತಾಡಿ.
ಇಯರ್ಫೋನ್ ಡಿಸ್ಕನೆಕ್ಟ್ ಮಾಡಿ.
Dr. Chandrasekhar sir, you have any suggestions? You have to unmute yourself.
Suggestion for his technical problem?
No, on the way ahead.
Okay. So I think it was a good.
Can you hear me now? Can you hear me?
Yes, we
Yes.
can hear you, sir. You please give your welcome note.
Okay,
Yes.
okay, sir. Sorry.
Yeah,
Sorry for
yeah.
the interruption.
Please continue, sir.
Yes, sir. Yes, yes, sir. Sir, can you see, sir?
Now we will share.
Sir, can you hear, sir?
Yeah, we can hear you, doctor.
Okay,
Please
sir.
continue.
So, from IDA Bangalore branch, I welcome all the IDA members and our speaker, Dr. Chandrasekhar Janakiram, sir. So, this is our office bearer team. Dr. Srivastava, President, Dr. Vidyasagar, Honorary Secretary, Director, and Dr. Prashant, myself. So, this is our to commemorate the World Oral Day. From the IDA branch and the Ministry of Welfare, Family and Welfare, there was instructions. Sir. So, we have been conducting the series of CDE program. So, the first CDE we are conducted on 20th March, where we had 2 speakers, and this was some of the photographs of our program, where we had a health program also conducted. And this is here where we have got a second webinar being conducted on World Oral Health Day. So the highlights of this is we have got 5 CDE points. It's entirely online, and we have been giving the e-certificates also, and the program is of free. So here we have got 5 CDE programs. The first one is on oral diseases and neglected epidemic today by Dr. Chandra Janakiram. Second program is on modern oral hygiene days. It's on 6th by Dr. Kishore HC. Third, effects of stress on oral health, role of yoga in its management by Nagashri SR on 10th. Oral cancer and potential malignant lesions, diagnosis and management by Dr. Subhashini R on 11th. And last, we have got malocclusion and preventive orthodontics, a pediatric perspective from Dr. Ravi Kumar on 12th. So before we start, I would like to introduce our esteemed speaker for day, Dr. Chandra Janakiram, whom I know since my BDS days. Sir has got varied degrees. He did his Master of Dental Surgery in MDS from the RGHS in the year 2001. Later, he has done his Diplomate in National Board Examinations DNB, Master of Science PhD from Amrita University in the year 2011. He is a residency in Dental Public Health and Diplomate in Dental Public Health. This is very few to mention about him. He has got around more than 100 publications and abstracts, and he has published various books. And he is a peer reviewer for around 22 journals, out of which these are main. And he has been working on various funded projects. These are some to mention here. He is a member of on research mentoring. He has been in doctoral committee, and he has been guiding a PhD student, around 5 students. He has been mentoring graduate students for mastering dental public health, around 14 students. He is a certification examiner for both MDS and undergraduation, and also certification for examiner of doctoral, around 2 students. He is a resource person for various international and national platforms. And this citation analysis to mention, H index is got around 22. So those who are doing research or into research can understand this high value which sir has got, a high impact. And is a member of various professional bodies and IEC committee. He has been awarded with various honors to mention active bioethics member from the Kerala State Indian Program of International Chair in Bioethics in the 30th November, and has got a Lifetime Achievement Award by Indian Association of Public Health Dentistry, Kerala Chapter 2020. And he has been a gold medal postgraduate student from the MDS from the Rajiv Gandhi University in the year 2001. He has a total teaching experience of around 25 years, and currently is a professor and heading the chair at Department of Public Health, Amrita Institute of Medical Science, Amrita University, Cochin, India. So Dr. Chandra Janakiram sir, to mention about you, is a very good-hearted person, down to earth, ever smiling, cooperative person. Anytime we ask, is very much appreciate accepting our invitation, and thanks for accepting and coming forward, sir. Now I request Dr. Chandra Janakiram sir to please proceed with your presentation. Okay.
Doctor, you can unmute yourself, please.
Yes.
Thank you very much, Dr. Prashant, for inviting me for this Oral Health Day celebrations and a part of this webinar. And it was a wonderful presentation by the Mr. Sunil about the data, what he gives about the pharmaceutical companies. And those numbers are really mind-blowing, and I think that helps my presentation to, especially with why oral diseases are neglected. I think those numbers, note on those numbers, because I'm going to use the same numbers in my presentations also, but not as a pharmaceutical companies, but as a diseases. Thank you so much. And also it's good that you're organizing this webinar to make, some of the oral health issues to be known to everybody. And I think involving the partnership with the pharmaceutical companies is a great initiative as such. Thank you so much. I'll be beginning my presentations. When I thought that Oral Health Days celebrations, and we thought that we should be able to share knowledge about why oral diseases are given less priorities when compared to the other diseases, and where does we fall into the health stream or health sphere or healthcare system in any communities or countries as such. Okay, so oral health, has been issues which is called as neglected global health issue, or it's sometimes called as silent epidemic, or sometimes called hidden epidemic actually. And there are many reasons for that. We just look at the numbers first, why it is epidemic, and then we think what should be the reasons for that and how we can able to do it. I'll be very brief in my presentations, and you can interact me and ask me more questions wherever you feel it so. So some mind-blowing numbers. Dental caries affects around 33.5 billion population worldwide. It is from 2019 global burden of diseases study. And untreated dental caries is the most common health condition globally than any other condition actually. And dental diseases, untreated dental caries is one of the most common diseases in the childhood also. And severe periodontal disease affects about 10% of global population and is a leading cause for the tooth mortality. And oral cancer is the 11th most common cancer worldwide. And global impact of dental disease is significant because what we are trying to understand this prevalence number or frequency is terms of how much the cost involved in that particular treatment or management or diagnosing is around 4.6% of global health expenditures goes for dental health. And imagine this is the amount of numbers we have. And does this number have any value? Yes, it has a value in the sense, are we taking it seriously? Because as a public health, we always look at numbers. For us, number is important. If it is anything less number, we are not very concerned. If it is more, then we are more worried actually. If COVID cases now is around 3,000 every day, so there is not an issue. Now, if it becomes 30,000 or 3 lakhs, then we get worried. Oh, that's what the value, this numbers, even though we have these numbers, and why we fail to make any changes in oral health in the healthcare system there. So if I just wanted to do some few terminologies which I'll be using now, one is DALYs and year added lives. So these DALYs or disability adjusted life years is to measure an overall burden of a disease. So because oral diseases are more of morbidity diseases and not mortality, doesn't cause mortality. So we need to understand the burden of the disease, not only in terms of numbers, but in terms of burden, how much it's causing the ill health to the population or to the person, or disability it is causing and affecting his routine life. So years lived with disabilities, YLD, and years life lost. So healthy life can be, some of these points where we are getting this blue options here in a life or disability and how much it's contributing to the earlier death. If he doesn't have disability, what was his expected life expectancy? So this measure will help you to understand the morbid conditions and disability conditions or the morbid conditions of the oral diseases. So if a person lives with a periodontal disease for 5 years and experiences significant reduction in the quality of life, during that time, the life years added associated periodontitis for that individual be greater than those with a shorter duration or experience of symptoms. For example, if a person dies prematurely from a disease that typically reduces the life expectancy by 10 years, so those with live with the disease for additionally 5 years with significant disability, the DALYs for the individual would be 15, and that is 10 years life loss plus 5 years of disability, 15 years. So this is how a numbers is calculated. So these numbers will help you to understand the next, statistics, what I'm trying to project it. So, so it is all measured in DALYs. If you look at, different oral diseases, which are from the, global burden of oral diseases study published in 2017. Globally, DALYs accounts for around 275 DALYs for the oral diseases, and it is per 1,000 population, per 1,000 actually. Now, when you look at among them, the red one, edentullism, is the one which is creating more problem here. That is because in people living with the poor countries or second world countries, it accounts more because most of the consequences of the oral diseases are turning into be a edentialism there. So, and you know, if you look at these numbers are very significant for us to say that even though the disease is large extent, and also, but the problem is it is creating more, you know, adverse consequences on the on the oral health and on the general health. Now, how it is that? Because once there is a loss of teeth, there will be a hypofunction of the oral cavity. Once there is a oral hypofunctions, that leads to the frailty, physical frailty, because people can't eat good food, protein food is not there, so that causes sarcopenia and then the physical frailty. And this has been proved in those countries which has geriatric populations are high, especially in the countries like in Pacific countries like Japan, where the problem is about frailty or hypofunction rather than about the caries or periodontal, because the number of teeth have come down there because of these diseases. And the question is how to increase, how to, again, it follows the same system as reduction in or prevention approach for the dental diseases. So prevalent cases, if you look at the disease global estimated burden, diabetes, oral cancer disease, and other disorders by socio-economic condition of different countries, and still it is very high, and it has reached the level of a public health significance, but still the communities and countries are reluctant to look at these numbers to take a cause for the oral diseases. So there are three studies were there, periods of time they have estimated the oral diseases global burden to 1990, 2015, and 2019. And if you look at the changes from 2019 to 1990 to 2011-15, every diseases have increased, oral diseases have increased, in millions actually, and people are suffering from that. So if I say, what it means to you for this table or the next table, it shows that every mouth in this world has some sort of a health problem, oral health problem. They have some sort of oral health conditions. So there is invariably, there is no mouth in the world where it doesn't have any diseases, oral diseases. So that actually, this is what I was trying to summarize with these two tables to say that the conditions have enormous there and frequencies there. Even if you look at the dialysis per 100,000 population for all oral health conditions combined one, not as individual diseases, you can see that there is no map, there is no area in the map where you can show which is very less than one. Everything is more here, and everybody has some sort of oral diseases. So global patterns of prevalence of incidence, because untreated dental caries is the most sensitive indicator for oral diseases, because when there is a caries which is active in progress and it is not being treated, and that is a more sensitive indicator for oral diseases. If you look at untreated dental deciduous teeth, it's incidence per capita or prevalence option. You can see how it more on preschool children and school children, and permanent teeth again it goes back, and it goes up to or increasing up to 15 years, and then it gets plateau there. Cerebral periodontal disease, again you can see global incidence. It just you can look at how it picks up from the 20 years and goes, and then tapers down to 90s or 100s, and the tooth loss there. And tooth loss starts at the age of around 50 to 60, 35 to 40 year, and then goes upward. So if you look at these conditions and these insensitive indicate consequences of that particular disease, oral health conditions, and it is when you the numbers are very high, the incidents are very high, and this leads to a situation that why people are not calling an oral disease and a pandemic rather than an epidemic, because pandemic affects everybody around the world. But still, they can't call because there are so many political reasons which we'll discuss at the later stage. So this shows the same thing for all oral conditions. This is different from the previous one, and it includes both the sexes there. So this is the 2019 story where it shows the incidence of dental caries in DECIDST, prevalence of dental caries in the DECIDSTs, and you can see the lighter version. This is the incidence, and this is the prevalence of DECIDS. This is the darker blue, which is a hard, solid line, which gives incidence, and this is the prevalence there. So even though if you look at the permanent teeth, and the caries rates are very high, incidence is very high in these age groups, and also you can see the DMFT rates also prevalence will be at the same level, but going along with the parallel to the incidence. So these are the numbers. Again, it shows about the YLDs, the years added in untreated caries by permanent teeth by age in 2019. And if you look those number of incident cases, you see the age group and both the gender, male and female rates, and you see those graphs gives us a trend how the oral diseases are prevalent in incident and prevalent in these age groups in genders, and how it is running very high across the frequency across the populations. So if you compare global diseases and also on selected NCDs, now why do we use NCDs as? Because oral diseases are grouped under the other NCDs. There are 4 NCDs which are very main, that is the cardiovascular diseases, diabetes, chronic respiratory diseases, and cancers, and mental disorders, eye diseases, then road traffic accidents, and the oral disease comes under other NCDs. Even if you look at this global picture of all the diseases, the oral disease accounts for enormous number of numbers, and everybody has it. But still, the amount of the priority is given to the cancers or cardiovascular disease are different from what is given to the oral diseases. So if you look at burden of oral disease in India, this is the only information which we are available from 2005. This is in a government document in Niti Aayog. 50% of people are suffering from dental diseases, 45 people are from periodontal disease, and so on and so on with other diseases there. So it follows the same pattern, but in global oral diseases we don't have region specific are there, but not country specific there. Now, when we want to understand the numbers of prevalence, then it comes with the cost of the disease actually. Cost of healthcare conditions in treating them or managing them or diagnosing them. And dental disease also is no far less than other diseases like NCDs. Like 90 billion euros are required for, when compared to the diabetes, cardiovascular, cancer actually. So the volume is more, and that's why the number is more. Another reason is the cost of dental care is not covered by the government. It's almost all the countries covers by the out-of-pocket expenditures. Whatever is that, whether government spends or individual spends, the cost of dental care, or cost of treating a dental disease is very high. So if you look at an individual will spend around in Australia around $432 per person for dental service per year, and it's a huge cost actually. And last year, the last 2021 data shows that 136 billion total annual cost, which includes direct and indirect care to the dental industry, costs a huge amount. So, economic burden of periodontists, if you look at, the managing a periodontal disease in UK, the National Health Service spends around 2.8 billion in 2017, just to add on to that, that is the cost health budget of Kenyan government for health budget. So one particular disease of oral disease is so enormous amount of money is required to treat, and NHS is a free service because it is care under NHS, and people don't pay anything on that because they pay high taxes. So naturally, those cost of care is enormous, and imagine that budget is equivalent to the and government in a Kenyan government health budget. Even in India, in 2008 report, in oral health care report, if you look at that, $5,000 are required to treat every child at 12 years for the DMFT of 2. So each child has a DMFT of 2. Imagine that was the DMFT value given, and if you calculate by any how much is the treatment required for that is $5,000, which is equivalent to the child's health budget. So the cost of treatment of dental treatment is very high, and but again, it can be prevented by simple means. And if this explains you that why people or why government don't take the dental care into important, because the cost is more. Not necessarily every government around the world, if you look for barring few people, few countries, everybody makes the dentistry or dental care as an outside their care, and it should be borne by the individual rather than by the government. A few, if you leave out few countries as such. So look at priority for oral health in India. It's very low because we spend very much less for the healthcare as such. But I imagine you think of what would be the contribution to the oral health there, and we don't have any budget for oral health. Even if you look at for RTI ways of method getting, you don't get anything but oral health. So priority for oral health in India, even though National Commission for Macroeconomics and Health have indicated that oral health is a top priorities among the 17 top priorities for health conditions, but still, the separate budgetary allocations or a policy or a program for our public health approaches is very less. So that's because there are various reasons, because these are reasons are intrinsic reasons, because oral diseases are chronic in nature, and they are not single cause. It won't cause by single factors, and it is like common risk factors, and there are clustering of factors, and many factors contribute to that oral diseases. So it is also modified by the the social determinants of the oral health, and naturally so many things are involved in the causation of disease, even though it is an invisible plague, but it includes psychosocial factors, proximal factors, distal factors, and then biological factors there. So involving a policy involving all these factors is the need of the hour, and that becomes a challenging or complicated to any government setup. Even we think that the dental plaque, what we see is which causes both the diseases, because both are plaque-induced disease, dental caries and periodontal disease, but the factors affecting the formation or destruction or prevention of plaque formation is influenced by macro factors, macro elements, and macro determinants, and that is the one reason. So where certain things cannot be a biologically way to treating the oral disease, it requires a structural structural approach to these determinants, especially social class, education, or macro elements as such. So another part of the story is that oral health has an intrinsic connection with the systemic health, and the saddest part is that my personal belief is that dentistry having a separate profession as medicine is the biggest handicapped situation we have in promoting oral health. The reason is if you look at back the history, history says about why dentistry became different, and why not pediatrics, why not gynecologists, why not mental health. All are comes under one system, and this comes in separate. No doubt you say that no, it is all same system, but still we have dental medical divide, and divide is there everywhere. And so the divide is, we get, divide is due to some due to a chance rather than choice, because you look at say 18th century, in 1848, where Maryland School of Dentistry was formed. They started as 20 weeks course in dentistry, but they told that they don't have a space in medical college to accommodate those dentist training programs. So can you take the other part of the campus where you have separate building and then go there? So what happened was, it was by chance, it became like this separate, and it evolved as a separate university degree and training and so many things. And it became everybody were working in so silo that the dentistry and medicine became separated. And even though teeth and mouth is not separated from the rest of the body, but the profession is getting separated, and that's where the problem arises. So there's a historic reproof of that, and thinking that if you are in separate, you can do better for the oral cavity. But actually, when you look at the dentistry diseases and oral diseases, they are not separated from the systemic diseases. They are all in, having some nexus there. And when we are trying to use a coordinated approach or integrated approach for the diseases, it works better. The evidence shows that it works better when compared to the standalone effects. So, how does medical profession works? If you look at like this, health issue, primary health care providers, then we have a specialist and super specialist there. But in how does dentistry works? We have a health-related dental issue, primary health provider dentist. A person having a tooth pain will come to any health-seeking, health providing center there, and people will provide care, emergency relief. But rarely the person goes back to a person who can give you a care related to the dental care, and that referral system doesn't occur in there. And that's what the problem exists there, where integrations and coordinated care doesn't exist, and patient is lost in that transition, and the disease is getting more upper hand, and that's the reason why you see these numbers high, because as the cost of dental care is unaffordable to even to countries like US. US don't provide free dental care to everybody, but they can provide medical care because the cost involved there. So when you look at dentists and physicians, they work differently for the same when the disease has nexus with them. So if you look at the periodontal disease, tooth loss, caries, or any other oral health conditions, invariably has some connections with the systemic disease. But disease has no borders, but you look at the dentist and physician as the borders, and they say, I don't know. Dentist doesn't know about so many things about medicine, and physician hardly knows about, even cannot pronounce the dental diseases names, to get correlated with common NCDs there. Medical and silos, these silos, they work differently there. And there is a question that if you have any issue, then we try to refer them and back, and we don't see that the cross reference occurring between the dentist and the medicine fellow, because hardly they have understood what is the relationship between these two conditions, and how to work in an integrated care, and what are the entry points is not understood clearly but it is understood in case if you are if there is a problem between the CVS problem with a CNS or a neurologist with a cardiologist, they will work better in their system, but not in when it is outside. So when they think that dentistry is outside, so they won't work properly. And this problem exists everywhere in the world, and now the people are starting thinking that we need to do some integration. There's a lot of money is poured on research of integrations, because they understood by insurance companies that if we work together, if there is a coordinated care between dentistry and medicine, then the cost of dental care will reduce, insurance premiums will come down, and dentistry can be included into the medical stream as an insurance mechanisms. So where what we thought before in 1980s and 50s and all, oral diseases means we were thinking oral diseases were dental caries. Now every oral health goals, if you look at previously what they are framed, everything was related to the dental caries and tooth loss. Never was anything about periodontal. If you check it, go back and check all the goals, never they mention about dental periodontal disease. Now dental caries have been stabilized, and people are thinking that they are not, the numbers are not very high, DMFT values are there, but the volume is more, but the DMFT values are less. So now the question here is, which is the diseases now they consider as most prevalent as oral disease? Now it is periodontal disease. And periodontal disease is the most common diseases in oral disease now, because the average span of occurrence is very high and it has connections with systemic condition. Now, no more the periodontal diseases are considered as a local factors or causes by local factors, more of periodontal medicine actually. So because it is related to the systemic diseases there. So now the new connection has thought that it is more of periodontal medicine than periodontal disease actually. So if you look at those risk factors for oral diseases and common NCDs, it's almost similar. So it gives this is one of the important thing for us, and it is a some sort of a tool for us to understand that if we in integrated approach add the oral disease NCD prevention, the disease will come down better. Because if I want to talk about or reduce about so many things about smoking, diabetes, obesity, stress, which all relate to periodontal disease, it's also related to the other NCDs. So having a common risk factor approach is a rational approach for reduction of both NCDs and oral disease. So cost of reduction will come down, and patient is able to manage better of both the diseases rather standalone care. So common risk factors approach is the one of the rational approach, has been proposed 2020 years back, and still it is having a lot of issues with the data and evidence, but still a lot of research is going on to show that evidence. And if we do a periodontal outcomes properly, then diabetes outcomes will come down in a care settings, not in a research setting, in the care settings. There are a lot of demonstrating projects are going on to understand the diseases. So oral disease consequences are many. One of those things are malnutrition. ACC invariably leads to the malnutrition, and malnutrition leads to ECC. Nutrition older people leads to the frailty condition, physical frailty, quality of life is affected, and other cardiac parameters and school performance. So in general, the consequences of oral disease are enormous, and it can affect the routine life. So this is what the perceptions should be enhanced with the policymakers and the people, because they think that dentistry is again a cosmetic one, and it's just you can live without teeth also. That's notions they have it in the mind. So if you look at a BDJ poster in 1940, it shows about general health, and unsound teeth can undermine general health, but still the connections are not conclusive there in case of terms of care, even though pathophysiology is established, but not as a care. So why there's a problem? Because lack of oral health examinations, lack of knowledge among the physicians, lack of knowledge about common risk factors approach, as is the issue which is a problem of both dentists and the medicine people to come together to combat oral disease. Lack of oral chains. We don't have cross-referral chains which are under the same roof. So even if you look at the recent one, 2022 oral health report a global status report, the oral disease remains the most prevalent conditions among all the conditions there, but nobody is taking the cost of it to understand should we combat this oral disease or not, because a lot of issues are there in the political priority of the oral health. So, need to integrate the medical and dental care oral health reflects general health. Oral diseases impact the systemic health and quality of life, and simple non-invasive periodontal therapy results in 40 to 70% reduction in medical costs and hospitalization who had diabetes, coronary disease were. And this example of economic example and evidence is important for them to understand, and that's how these type of research evidences are required for policy making. The political priority of oral health is less because not met because we don't know who frames the policies, whether they are relevant, actors are there, or political leaders. Oral health, does they give them a political dividends to make them as a priority compared to the other health conditions? And there are policy issues. We don't have research proper to make sure that we take this cause for the with the policy makers and parliamentarians, and we don't have guiding institutions where it can guide and tell that, okay, man, we do, so they are influential in doing that. So we don't have a think tank in the oral health situation to make an effort for take it forward there. So oral health, if you look at a dentist alone, cannot be achieved, and it is a multi-sectoral, and oral disease being a part of NCD, and a lot of social determinants are there. So it's never can be achieved by a dentist alone. We need a large number of people who are championing for cause of oral health. Otherwise, disease gets neglected. So this is in a recent Lancet publication. Oral disease is a global public health challenge, and even though we don't have data in many countries, but it remains based on the economic cost involved and the numbers involved in people who are having this particular type of diseases. So one cannot be healthy without a good oral health, and oral health remains a challenge. And even though the priorities are less, and the frequency is more, the prevalent and conditions are there, and one of the most prevalent conditions. And I think that the champions, the think tank, the perceptions among the people, among the healthcare providers are very low to take up this cause. And thank you so much. I would like to have some questions if you have. Thank you for invitation.
Thank you, sir, for your excellent presentation. Any questions from the audience? Any questions from the audience? Sir, okay. Dr. Chandrasekhar, sir, can you hear me?
Yes, yes.
Okay. Sir, what is the senior of oral health in our rural areas, sir, in India? So when you look at a world, because you have traveled throughout the world and you've got various experiences. So coming to India, in the rural setup, what is the condition of the oral health, and where we need to be more imparting our policies, sir?
Well, rural, it's like, we don't have a care in the sense if an individual gets a tooth pain, he doesn't know where to go. He goes to a first home remedy, he goes to the local healthcare provider, maybe a alternative practitioner or anybody as such, and they give a pain relief medicines and it starts there. But the oral diseases are not like when it is not, it can be managed by those people, because those people are only a people where you can refer those cases to a higher center. Now that is the problem. The healthcare services, oral healthcare services are not there in rural areas, or there only when there is a catastrophe is there of oral health condition. That is the one part of the story. The other part of the story is that oral diseases cannot be approached by increasing number of dentists or increasing number of dental colleges or services. It is humanly impossible. Even the countries like Canada or US have not used that approach by providing more dentists in every part of the world on their area and to increase and reduce. There is no evidence shows the number of dentists will decrease in oral disease. Even in medicine also. What is more important is the policies of public health policies and the community-based policies for prevention of dental diseases, which is most important one, because that is a whole population approach, and then comes the high-risk approach for people who are already having a disease. So I feel that in rural area or urban area, the problem is same, but the cost of care is more in urban area, because we have access to care, and the dental care is a lot of multitudinal problems are there, and the precision issues are there when trying to, because we work in 2 by 2 inches oral cavity, and we work in millimeters. The cost of the care is so most important approach is to align the oral health with the other health policies, and thinking of a community-based approaches and community-based prevention techniques, evidence-based, are more important than looking at the services which is not possible to give for any government.
Thank you, sir. Any more questions from the audience? You can raise your hand if any questions are there. You can raise your hand.
Okay, there's a question.
There's a question. Yes, sir. Can we make some projects like mobile dental vans to educate the people in rural areas to make them aware? So this is a question posted by Dr. Sunil Maid.
Yeah, thank you for that, Sonal. Can we make the projects like mobile vans, all those things, educate? See, if you look at the evidence from a Cochin database, health education, a standalone, a standalone program as health education program is not effective, because even if I make you aware of you have to brush your teeth 2 times a day, doesn't make sense, because it won't improve the health condition. Health education is useful only when it is in conjunction with other health programs, like you have a fluoride, or you have some sort of a sealing program, or some community-based programs. So it hardly you can find any effectiveness of that. It can only give you some small snapshots like mobile dental vans, because the cost of running a mobile dental van, cost of building a mobile dental is huge, and it is sustainability issues are very less. We look at people we need to look at the solutions which are acting sustainable. It can be given to a large number of people with a low cost. That's why the challenge comes at affordable technologies in using that. No doubt mobile vans can make, but it's limited approach, very, very limited approaches.
I think Dr. Sonal, sir, has answered your question. Now, one more question regarding our education things. So now majority of our students have been trained to do the fillings or scaling. But when it comes to a preventive approach, where do you think we need to impart more stress on the students? And also with our national education policy coming into, maybe we may introduce into our dental education in the forthcoming years, where do we need to impart a few things into our education, sir? Mainly for dental undergraduates?
Now, we have our system of what we learned from past 60 years in dental education in India is basically about looking at particular slicing the oral cavity into 9 parts and looking each part again slicing back. Like for example, what I'm thinking is we are looking at the oral cavity patient into a small slice of a class 1 cavity or a RCT or a cleaning, oral prophylaxis. What I'm trying to say is that we are looking as that as a patient there. We are not looking as a patient as an individual, where I'm trying to assess the risk factor for oral diseases in general, in totality, and trying to manage him in comprehensively. What I was trying to say is that when we have to look at the patients at the comprehensive level, looking at one person is able to manage the patient, the patient in a whole, rather than looking at a slicing there. Actually. So that will give him a better understanding how disease occurs, and also will able to manage the patient. Now, in the NEP approach, in the National Education Policy, or in the recent 2022, the competencies for revised curriculum for BDS, I think they have touched upon these issues, looking at patient as a whole, and trying to look at not as looking at each of the component of the particular oral conditions and treating them, but as a whole there. So when he's able to manage that, I think that way, the education will able. This is how the policies, this is how the systems are in place in other countries. I think that is what they are trying to bring out in our conditions also. I think it should be, that will solve the problem if we are able to successfully implement in all the dental colleges in India.
Any more questions? People can post the questions in the chat box. Okay, so I think Dr. Sir's presentation has touched on all the aspects and given an overview about the incidence of the oral diseases in the world and also in our country, India. So with this aspect, I thank our today's speaker, Dr. Chandrasekhar Janakiram, sir, to have taking this precious time out and having presented us with this topic and created an awareness about the dental diseases among our general practitioners. So once again, on behalf of IDA, I thank Dr. Chandrasekhar sir for excellent presentation and educative presentation, which has created an interest and awareness amongst us, sir. So thank you, sir. And I request Dr. Sunil sir to please present certificate as a token of appreciation to our today's speaker, Dr. Chandra Janakiram, sir. So we request you to please accept it, and we'll be sending an hard copy also at a later date, sir.
Thank you very much.
So thank you, sir. And thank on behalf of IDA, all the senior members of IDA Bangalore branch, state branch, for having given us support in conducting such a webinar. I also thank Dr. Srivatsaji, Principal KSDC Society Institute of Dental Sciences, for having supported this program, his wholeheartedness and his cooperation in conducting such a program. And I also thank our today's collaborator for the entire webinar series, Group Pharma, especially Mr. Sunil Chuprankar, who has been a backbone of this project. So thank you, sir. And I thank all the audience, the postgraduate students, once again for spending your time, valuable time with us. Thank you. We'll again rejoin back for the tomorrow's webinar at 2 p.m. Thank you.
Thank you very much.